The microanatomy, this is a picture of a separated myocardial cells. This shows you that the heart is not in a linear format like skeletal muscle is. The other thing that's important to notice about this microanatomical picture of a heart muscle is that it's connected together via this kind of irregular pattern, which allows the heart to rotate and to compress more efficiently. The actual interconnection between cells, you can see the nucleus is here. This is the nucleus of the cell. That means these are individual cells, okay? And they're connected via what's called intercalated disc. Okay? These intercalated discs allow the cell to talk electronically to the surrounding cell. So once electrical propagation is initiated, it then transfers from cell to cell, which gives it that pattern that you see, which is the contraction pattern. Okay? Without this, you would have an individual what's called myofiber or myocyte, okay, that would only fire if it was activated like a skeletal muscle. So it's very, very different than skeletal muscle. Ultimately, when you're talking about the actual component of contraction, this is both the same and in the heart as well as skeletal muscle. Okay, is a sarcomere. Okay, so if you want to talk about skeletal muscle, because a lot of times the physiology books will talk about skeletal muscle as a base unit, it does apply. Okay, preload, contractility, afterload, and rate are all dependent on this basic unit here. Okay, rate basically means how fast that sarcomere can get compressed. Okay, preload is the actual distance between the Z lines before the contraction begins. Okay, the wider it is, usually the better the performance. Okay, until you pull it too far apart, and that's called too much afterload, too much preload, and because you have too much distension, and then the sarcomere cannot contract properly at that point. Okay, if you compress it too close together, the Z lines begin to get closer. Okay, and you begin to see that here, this is where the Z lines would be, and that would basically make the actin basically overlap each other. And guess what happens at that point? You get no contraction. It can't compress anymore. So that's a low preload state. Okay, so preload basically tells you the distance between the Z lines before contraction begins. Afterload is the discussion of how much load is on that sarcomere during the contractile component. Okay? If you put a lot of afterload on something like this, it's not going to do anything. It's just going to try, but it's going to do what's called isometric contraction, which means it's still compressing, or trying to compress, but it's not moving. Iso. Okay? The way you think about this is when you take something really heavy, let's say you've got somebody's book bag, okay, and it's so heavy that I can't lift it, and that's what's isometric contraction. Okay, it's the same kind of concept. You're still working, and your muscles will build with that, okay, but it's not very efficient. You're not really doing any effective work. We're back to the basics again. We're looking at how the ATP binds to the myosin heads. The myosin, which is of course attached to the thick filament, which is the myosin. Okay, and you have the myosin heads. You will not get any contraction at all. Okay, you don't get any contraction unless the myosin head can actually bind to the actin filament. Okay, and the way the myosin head will bind is only if the calcium binds onto the the troponin complex, okay, up here. See the complex up here? When the calcium binds to this point, the fiber that's around it is preventing the myosin head to bind, rotates, moves out of the way, and then the myosin head binds to it and then pulls and causes a contractile force. So what initiates contraction? The answer is calcium. Okay? What allows for the workload to be done, okay, is going to be the ATP, okay? But the answer is, when you're asked what initiates contraction, it's not ATP, it's calcium. Okay? Once a contraction takes place, the myosin head will stay attached and will not allow relaxation to take place. Okay? For the relaxation to take place, you must have ATP to go in there, break the myosin head, and reload the myosin head. Okay, so ATP basically allows for proper relaxation to take place and to reload the myosin head. If the calcium is still attached, what will happen then? It will rebind and go again. Okay, so termination is dependent also on calcium. You have to reuptake the calcium away from this complex to let this reconfigure so the contraction will completely stop. Okay? So initiation and termination are calcium. Relaxation is ATP driven. Now, why is that important clinically, pathophysiologically? If you deplete somebody's ATP, then what we're really talking about is not that the initiation of contraction and ending contraction. What we're actually talking about is the relaxation phase of the contraction. So what happens is if you get ischemia, okay, no more ATP is being produced, the heart becomes stiff. You've all heard that, okay? And what you're seeing is not because it's from the calcium working, it's because there's not enough ATP to allow the relaxation phase to take place. Okay? You resume giving oxygen to that tissue, and it rapidly relaxes again and starts functioning again. Okay? Now the SR is the next set of network. The SR is extremely critical for calcium regulation. Okay? The myocardial cells are very specialized in the sense that they have to have a mechanism in place where they can control calcium, which is very, very dangerous to the cell. Okay? And the way it does it is by this extensive network that's right against the myofibrils. Okay? The sarcoplasmic reticulum basically is a specialized structure that holds all the ionized calcium in it that only allows it to be released during voltage-dependent status. Okay? So when let's say the pacemaker cell comes by there, it causes the cell to depolarize, which is the surrounding myocardial cell that's right next to it, which is the cardiac myocyte that's actually going to do the contraction. As soon as the cell depolarizes, you get the fast sodium channels for the cardiac myocyte to fire, and when it depolarizes, it then causes the SR, which is right next to it because it's voltage dependent, to open its gates. Okay? Calcium will then pour out of the SR, and also the plasma membrane on the outside of the cardiac muscle cell will also cause voltage-gated channels also to allow ionized calcium from the outside world to come in. Okay? So you have two sources of calcium in the heart. Ionized portion outside and sarcoplasmic retained calcium inside. Okay? They come into the cytosol. It then goes to the actin portion, binds to the troponin complex, and causes a configurational change, which then causes the contraction to take place. That's how I want you to understand the sequence. Okay? So if you have a low ionized calcium levels, what's going to happen is you're going to deplete the sarcoplasmic reticulum eventually of ionized calcium, because you do lose it a little bit during the workforce. And so contractility is going to drop off if your ionized calcium levels drop, okay, which is kind of important. You have clinical situations very often where you actually drive calcium levels very quickly down, and you can get symptomatic from it. Kind of situations like patients who develop blood transfusions, okay, because the citrate uptakes a lot of this ionized calcium, and as a consequence, you start getting symptomatology from that. Okay? Does that make sense? Anybody get lost? Sure. Mm-hmm. That's correct. Okay. So she had a question: what are the two forms of calcium? One's in the SR, and the other one's outside the cell that comes into the cytosol. Okay. Electrically, the heart is a very specialized structure. Okay. It has intrinsic pacemaker capability inside the cells. So if you take a pacemaker, if you take an individual cell out of the heart, any portion of it, and you put it in a petri dish, it'll fire by itself. Okay? If it's a pacemaker cell, it will fire at a rate of between 60 to 80. If it's an AV node cell, it'll usually fire at 40 to 50. If it's a ventricular cell, it'll fire at around rate of 30. Okay? So each cell has its own intrinsic capability of firing or self-initiating. Okay? Most of the time, when you're talking about cardiac myocyte cells, they don't get activated until they get a sensory signal or electrical signal through the conductance system, because it's much more rapid than the self-actuating system of the myocyte. Okay? So usually it's not an issue. But the good thing is if you do lose it, you don't lose everything. Instead, your heart rate drops down to 30. Okay? The SA node is a primary pacemaker in your body. It's located usually in the right atrium, and usually right below where the superior vena cava entrance comes in. The SA node initiates fires at usually going through 3 fibers. Two fibers go through to the right atrium, and 1 fiber goes to the left atrium. Eventually, the signal gets incorporated together into the AV node, where the electrical signal is actually held for so many milliseconds to delay the signal enough to get atrial kick out of it. Okay? When you send these electrical patterns to these actual conductance fibers, the surrounding myocardium, which in this case is the atrium, okay, it doesn't have a neurotransmitter that's getting activated, not like skeletal muscle, which requires nicotinic receptor activation. Instead, as the electrical signal goes through, the electrical signal propagates outside of that conductance via these gap junctions. Okay? So it fires that component in kind of a syncytium in 1 unit. Okay? And it's very quick. So you have to have enough time, though, for the atrium to fully empty, and the AV node's responsibility is to hold that long enough for the atrium to empty. Okay? Normally, the atrium comprises around 15 to 20% of the actual left and right ventricular preload. Okay? If you lose it, that means you lose 15 to 20% of the preload. If you have a lower compliant ventricle, it's from ischemia or hypertrophy, so it means it's a stiffer ventricle, then the actual atrial kick can comprise up to 30 to 40% of the preload volume injection into that ventricle. So if you lose that person's atrial kick from either atrial flutter or atrial fibrillation, that person can become symptomatic in a hurry. Okay? The electrical signal, once it's held by the AV node, then eventually fires. Okay? It then sends the signal very rapidly to what's called the His-Purkinje system, and it basically causes the ventricle to contract at that point. The disease processes we'll talk about next in the next hour will be on electrical problems of this sort. There's 5 phases to cardiac action potential. We talked about this last semester, so I'm going to go over it a little fast. Phase 4 is basically rapid upstroke. It's the excitation phase. It causes depolarization. Threshold potential must be attained. And it's usually the fast sodium channel is the major contributor when we're talking about cardiac myocytes. In phase 1, you get early repolarization, which is you get inactivation of the fast sodium channels. And you begin to have a transient outflow of potassium. And chloride may also precipitate and pull back and be allowed to be going out, which makes it more negative inside the cell again. But what actually is very important is in phase 2 for cardiac myocyte. That's where the actual workload's being done. You get what's called the coupling effect. Okay? And this is where it's important that I just talked to you about before. The calcium is not only coming in from the outside of the world, but it's also coming in into the cytosol via the sarcoplasmic reticulum. If you didn't have any form of negative charge being in place, then the charge would actually go up to be very, very positive, and you would, it's not that it would be bad, you get a very good contraction, but the bad side of it is that you wouldn't be able to get it to repolarize in any degree of speed. And so you wouldn't, next heartbeat would be very slow. So what the body does to try to give it a steady plateau phase is that it leaves the potassium channels open during this phase to let negative charge go out, so it equilibrates and gives you a plateau phase. For every 1 calcium that comes in, which is 2 charges of calcium, it's a mill equivalence, how many potassiums would have to go out? 2, right, and that's what happens. So that shows you how much volume potassium is coming out. And that sort of makes sense to you if you think about it. You know, if you see somebody give succinylcholine, they die of hyperkinemic arrest if they have this neonatal receptors all over the skeletal muscle. Okay? It doesn't happen to the cardiac muscle. The cardiac muscle is not going to give you hyperkinemic arrest from succinylcholine because there's not what in it? There's no nicotinic receptors. Okay? So it doesn't matter. Okay, but what it does do is eventually the potassium pours into the bloodstream, and then the potassium gets around the heart, and what happens to that? The potassium can't leave the cell inside the heart. Okay, so you can't get that plateau effect, and the pressure goes up really high inside the heart, and then for a voltage, and then you can't get to repolarize, which then eventually leads to cardiac standstill or asystole. Okay. Phase 4 is your resting potential. Phase 3 is when the rapid repolarization. That usually happens with rapid current of potassium going out, but at that point also calcium channels begin to close completely. Okay. Now what's interesting is the calcium channels are voltage gated. That's how they get opened, and they are time dependent. So it's going to contract for a certain amount of time before they automatically close, which is pretty cool. Okay, it's like throwing this door open, and then I can get the hinge to shut back depending on how much time I want. Okay, and that's how we actually alter the actual contractility. Okay, do you guys know how these things work? These doors work? If I open this door, what makes it close? There's a hinge in it, yes, but there's also a hydraulic component to it. There's a spring inside of it, and a lot of these have hydraulics in it. So you can actually winch it in tighter to make the door close faster. Okay, so that would be the same kind of a thing where the heart is basically wants a greater contractile time. It basically allows the door to stay open longer, getting the calcium coming out, and it continues to allow the contraction. If I want the contraction to be less, then I close the doors more rapidly. Okay? So the body has the ability to regulate contraction velocity based on hormonal changes as well as different sympathetic drives mechanisms. The ventricle is not controlled at all by parasympathetics, at all. Okay? The only thing that the parasympathetics controls is the AV node, SA node, and the atriums. It does not control the ventricle. Okay? So it does not control. It may control to a certain degree atrial kick phase, but it does not control ventricular contraction or contractility. So this is the actual waveform that you generate from the cardiac myocyte. Notice that the working pressure that you have, or the working millivolts that you're working is minus 85. So you have a great amount of workload that you have there. Your phase 4 is your resting membrane potential. As you can see here, it's flat, as it should be. The pacemaker cell doesn't have that, it goes up. This first portion is the fast sodium channels opening up, which accounts for phase 0. Phase 1 is where it starts repolarizing because the sodium channels begin to close. And then you see the outward occurrence of potassium going outside as well as inward movement of calcium, which incorporates into phase 2 plateau, and eventually termination, which is phase 3 of calcium with potassium still being allowed to go out. Eventually you go back to your resting membrane potential of phase 4. The importance of this gradient is that you have this established by these electrolyte differences between the intracellular component and the extracellular component. The intracellular component concentration of sodium is around 7 milliequivalents per liter versus sodium outside is 144 milliequivalents per liter, which is pretty high. So the gradient is basically established to allow sodium to rapidly come into the cell. Why do you think the body uses sodium, though? Why didn't it just decide to use potassium as outside the cell? Why would it use something so selective as sodium? That's right, smaller. It's half the size of potassium. So you can actually make a channel that's easy to control without allowing another molecule to come across it. So just by opening the pore just a little bit, it's very small, the sodium pours through it without potassium coming out. So you can regulate it. Okay? So what do you think happens when you open a potassium channel? Sodium can come in a little bit, but the flow is so velocity of potassium going out that it obstructs greatly percentage of the sodium coming in. So it's usually not a factor too much. Okay? It's like opening up a spigot, okay? And you have a hose and you're trying to run at it. Okay? You're going to feel it, but it's going to be uncomfortable, but you may get through it. But not many people, if they're small, they're not going to get through. That's the kind of concept in that respect. Potassium's gradient is huge inside. Intracellular potassium concentration is 151 milliequivalents per liter. So potassium inside the cell is actually very safe. So when we talk about hyperkalemic arrest, the treatment modality is to push the potassium back into the cell so the patient's safe. What kills a patient is high levels of potassium outside the cell. And what also kills patients is hypokalemia as well. You can get pacemaker problems as well as pacemaker generation issues as well. Chloride is very high in concentration outside the cell and very low intracellular. So that tells you something, right? What must be inside the cell? What's negative inside the cell in comparison to the outside world? What's that? Say it. I didn't hear you. Don't know? Okay. What's inside the cell that's very negative in charge? Proteins. There's lots of proteins inside the cell. Okay? So that's what makes up a lot of this, plus you have a certain degree of bicarb in there as well. But really the cells have a lot of proteins in it, so it accounts for a lot of the negative charge. If you look at pacemaker cells, on the other hand, they're a different kind of workload. Pacemaker cells work at a standing pressure around minus 60 millivolts, that's your resting memory potential. There's no fast channels in this case. There's no fast sodium channels at all. Okay? The maximum negative voltage is due to the sodium-potassium pump to a certain degree. Okay? Phase 4 in pacemaker cells is not flat, though. It has an ability to repolarize itself, and it's due to slow sodium channels. Okay? This is not fast sodium channels. This is due to slow sodium channels. Slow sodium channels allow sodium to come in slowly, okay, which then takes the phase 4 from being flat to constantly coming up until it hits threshold. Once it hits threshold, it's a voltage-gated, calcium channel dependent phase 0. Okay, it's not sodium. Okay, so it's a good test question. Okay, now the question you ask yourself is, geez, Dr. Nolan, you're really hitting the little micro stuff. And why do I care? How does that relate anything to what I do? Okay? And the answer is, when we talk about drugs that treat arrhythmias, you have to know the difference between myocardial cells and pacemaker cells. If I give something that's a fast sodium channel blocker, will it really affect the ventricular contractility? And the answer is it won't. Okay? What it will block out is it'll knock out. If it's trying to, sorry, let me back up. If I'm giving a drug that binds only to fast sodium channels, okay, it has no pacemaker effects. It will affect the myocardial cells, though. Okay? So if I give somebody a high dose of bupivacaine, bupivacaine is a local anesthetic that binds to fast sodium channels. Okay? Bupivacaine, unfortunately, also has the capacity of also affecting slow sodium channels, but really the biggest effect is the fast sodium channels. It's a more rapid effect. So because of that, the ventricle will stop contracting. Even though you will still see electrical activity going through it, the heart literally stops to pump. Okay, because you knocked out the pacemaker, not the pacemaker, but you knocked out the myocardial cells. Okay? And that's how you want you to start putting it together. When we start talking about calcium channel blockers, we're talking about specifically which portion of the AV node. It could be that it's the pacemaker component, which is a phase 0. Yes? There would basically no activation. If you can't open the fast sodium channels for a myocardial cell, you won't get it to even reach threshold. Okay? It just basically shuts it off. So you'll still see a pacemaker activity, but you don't see any contraction. It's EMD. You know, what I call EMD, you guys call PEA. Okay? Okay? Pulsus electrical activity is why you would get that. Now, eventually, bupivacaine does affect the slow channels, and then it suppresses it enough that you go into asystole. But that's later. The first thing you'll see is that you won't have a blood pressure, and you'll still have electrical activity, and you're going like, what the heck happened? Okay? And then all of a sudden, you'll see the heart rate begin to slow, and then it gets phased out because then the slow sodium channels get knocked out, and then you have nothing. That's not a good day to be in. Usually it means that you just got cardiac toxic from giving bupivacaine in too high concentration. Okay? So pacemaker cells are very different than cardiac cells, and when you would talk about how we regulate arrhythmias, this will become more important. So you have to understand this. Otherwise, when you get to the arrhythmia portions, you will not. Okay? Now, do I expect you to know everything like this? No. I will try to do the best I can to sort of make you learn it this way, because I think later on you'll incorporate it when you get to clinical a little better. Okay? You'll still be responsible for the testing. It took me a long time to get to that point, to learn enough in my head that I could keep it in. Okay? What I'm trying to get you to do is get the concepts down first, and then when you continue studying, you begin to try to incorporate it and learn it properly. Okay? Phase 0 upstroke is less rapid and reaches lower amplitude simply because it relies slowly on these slow voltage-gated calcium channels to do this. Okay, so it's not a rapid upstroke. And you think about it, you don't need a pacemaker to do a rapid upstroke because it doesn't have to do effective work. If I want to lift this bag, I'm using this bag continuously for example, if I want to sort of just lift it and just still does the work, it's fine. But if I want to get moving, I lift it fast and I want to do something and make it move. So when cardiac muscle cells are trying to do this, they're trying to lift it quickly and then hold contraction for a long period of time. If you hold your contraction too slow, then contractility drops off. Okay, and we'll show you that as well, how that affects. If you can actually slow these fast sodium channels, you can affect contractile time. Repolarization occurs via potassium efflux, just like anything else. So a safe answer pretty much in any form of cell that you're talking about of what actually causes repolarization, it's just very rare in medicine, so this is kind of a nice thing, is potassium. Potassium is responsible for repolarization taking place. Okay, this is the pacemaker cell function that you see. Okay, pacemaker here is showing the slow sodium channel leakage that's coming into the cell. Eventually it reaches the threshold, which is, imagine that you have the calcium channels are voltage gated. Okay, so what I'm doing is, here the sodium channels coming in, and I'm beginning to put force on the door. Okay, you see nothing happens. Okay, and all of a sudden I hit threshold. And the door opens. Okay, until I hit that threshold pressure. Okay, until I hit the pressure point where actually I put enough pressure that the door swings open. It's still getting electrical activity. It's becoming positive. But until that opens, that's when the calcium channels open. Once they open, calcium rapidly influxes, and that's why you get that spike effect. So it's not due to the sodium channel, but it's due to the calcium channel in that portion. So this portion here is due to the calcium. Okay, draw it on here. That's all the calcium here. And this one here is due to the actual sodium. There is some calcium coming in too, but the major component is really sodium leakage. Okay? Now the slope of attack, how fast that slope of attack can change is very important. Okay? If I can accelerate the slope of attack, the heart rate will accelerate. If I make the slope of attack decelerate and make it flatter, heart rate drops. Okay? Things that will make this pattern change will depend on parasympathetic and sympathetic activity. Parasympathetics make it phase 4 more flat. Sympathetics make it go up. Myocardial innervation is, of course, something that's established very early, even at the fetal stage. Unfortunately for us, especially children, is that they're predominantly parasympathetic at birth. The reason being is simply because there's not enough myelin sheath available quantity to basically myelinate all the fibers. So the baby decides to myelinate all the cranial nerves first, which is very important because he needs to suck and drink and eat and needs to breathe. So all the heavily myelinated fibers that are required for normal life are usually the parasympathetics that are coming out of the cranial nerves. The sympathetics that are coming out of the thoracic cavity, on the other hand, are not myelinated when you're born. Okay, so babies are parasympathetically mediated until the age of around 5 or 6. So they're more likely to go into bradyarrhythmias and die when hypoxia develops because they become parasympathetically dominant. As you get older and your myelin sheaths begin to develop, sympathetics take over most people's hearts as you get older. Okay? Now, sympathetic function controls the ventricle and it controls the blood vessels. Okay? Parasympathetic control is non-existent in blood vessels. Okay? It is existent in the SA and AV node, and also existence in the atrium. Okay? The sympathetics basically cover the whole heart plus the blood vessels. Now, here's actually where the topic becomes very important. You need to talk if you want to do this job. Okay? I had this alumni that graduated about a year ago. Okay? And he went to a very important interview for him because he wanted to be in this place. And he had 50 other applicants with him for 2 jobs. That's pretty impressive. Okay? And I asked him, where the heck is this place? And I found out where it was, and I said, wow, nice place. He can go skiing, so nice place. Okay? So the first question they asked him, because they had so many applicants, they had to figure out who was going to do well. Okay? They asked him, okay, how do you evaluate the heart? How do you evaluate a blood pressure? And everybody else was answering, well, you look at blood pressure and you look at this. And he answered it, and he got him his job immediately. He said, you look at the heart by preload, afterload, contractility, and heart rate. All the people interviewing him says, oh, so you know your stuff. Just because you knew how to talk. Okay? Because if you don't understand this concept, you can't figure out what happens in the operating room. So you must begin to think. Anytime the heart is discussed, it should be immediately like a template in your brain. Preload, afterload, contractility, heart rate. Every time you talk about a heart. From this point to the rest of your life. Okay? Any pathophysiologic condition, any kind of clinical condition, okay, you must go back to this first before in your discussion. Because if you do understand this and you begin to apply what you see is going on, you can develop treatment protocols. Okay? Each one has its individual treatment modality. If you develop a proper model of what's going on using these 4 things, you will get yourself out of trouble 99% of the time. If it begins not to work the way you're expecting to do, then you have to go back to what? Step 1. Your assumptions are incorrect. Because ultimately, we're not all-knowing. I wish we were, because that way we would never make any mistakes. Okay? But I can tell you, as being a physician for a very long time and having to make some very critical decisions in my life, I know that I've not made them all perfect. Okay? Do I beat myself up on it? No. But I do learn one thing. If I make a mistake or I see that something's not working, I immediately go back to my initial assumption that says I'm an idiot, and I got to go back to fixing the idea that I've developed. I didn't think of it right. Okay? And then it works out better for the patient. Okay? If let's say a patient is, I think they're in failure. That usually indicates that they're too much in preload volume. Okay? So my assumption is that we've overloaded the patient with volume. Okay? So the preload treatment of that is Lasix, which is a diuretic. It's going to reduce preload. And then initiating nitroglycerin. If it is truly congestive heart failure, that person will end up responding by dropping their preload, and then the ventricle begins to contract more efficiently, the blood pressure will rise, and all of a sudden the person will become much more alert if they're awake, and they'll have much more functionality. Okay? So if I did the correct thought process, it'll work just fine. But let's say I made a mistake. Let's say the patient really doesn't have a preload problem. Let's say the patient really has an issue with the myocardium is not pumping properly. Okay, and it's not from excessive preload, it's actually from too low a volume. So when I gave that person Lasix, I made the situation worse. And then when I really are going to know is when I hit the nitroglycerin. When I gave them nitroglycerin, now the person vasodilates, preload drops even faster, and then guess what happens to my blood pressure? It almost goes to 0. Okay? Which then it means my assumption is incorrect. I've got something wrong. Stop the nitroglycerin. And then, okay, what is my real preload here? Is it because the person is in hypovolemic shock or something that I don't understand? So I start looking at the patient and say, okay, maybe he's hemorrhaging internally. Feel his belly, and his belly's super tight. He's got 2 liters of blood in him because the surgeon missed one of the arteries. Okay? So that's how you have to think it through. Okay? You have to begin to work it through some model, and this works. The reason we also give you the initial model in your first semester, which is a pressure volume loop, is because it has all the attachment points on that model. Okay? So you really need to work that. Okay? And one of the things that I want you to do continuously when you're talking pharmacology, when you're talking about inotropes and stuff like that, build a pressure volume loop for that so you understand how you're affecting that pressure volume loop and how the medications work. Now, basically, preload is a simple concept. It's basically how the sarcomere length is prior to contraction. The importance is the sarcomere length, okay? The pressure volume curve mimics this actual preload by following the preload curve line, which is, remember, that's the lower portion of that curve, okay? It dictates basically on Starling's law. The Starling's law states simply that as preload rises, okay, cardiac output should rise. As long as you stay under the failure portion of the curve, that is true. That's the preload curve statement. If you're above the preload point where the cardiac output begins to fall off, that's a failure curve, and no longer does that follow Starling's law. Okay? That's the point that a lot of students just forget. They remember the first part, which is I give more volume, everything gets better. And that's true until you get into the failure model, which then if you give any more volume, it's going to get worse. So you've got to make sure that you know where you're at. We measure the actual volume via most directly by TEE or CT scan now with rapid CT, but really clinically we measure it hopefully by indirect means using a PA catheter. So we assume that the left ventricular end diastolic volume is the best measurement of volume or preload, but the correlation to that is left ventricular end diastolic pressure, and that's what we monitor using our PA occlusion catheters. It cannot be measured except with rapid echo and 3D echo. The next thing basically is measuring left ventricular end diastolic pressure, which is what we do clinically. Okay? This is a great study. If you ever have time to read this, I just found this fascinating from a purely scientific point of view. They actually took an individual sarcomere. Just think of that. That's pretty high tech. And they attached it microscopically between two little poles. Okay? And then they stretched the sarcomere, okay, until it reached around they gave it a preload volume, and then they measured how much force was generated by the sarcomere. And this looks just like what I taught you last semester, which is this is a preload curve, and this is the Starling's curve. Okay, so ultimately when you're talking about, we're looking at it as a group, which is Starling's law, but when you're looking at it as an individual unit, the sarcomere, it creates the same kind of graphical representation. As preload goes up, cardiac output goes up, just like it is. What's important about this is that right around 2.2 microns, that's pretty much as wide as you're going to get a sarcomere before it starts losing its ability to contract. And at that point, that's when you begin to go into the failure curve. We actually want our left ventricle to be around 2 microns at all the sarcomeres before they fire. Okay? That usually is about a PA occlusion pressure of anywhere between 12 to 15. Okay? So, or 12 to 18, depending on who you're talking about. Okay? So that's what we use as a pressure gauge to indicate to us what portion we're in. Okay? Now, the other thing that's important is looking at these pressure waveforms over time. This is a pressure over time curve, and each one of these actually applies to the pressure over volume curve, except the difference is that one is going in the linear time, this is linear time going this way, versus the pressure over volume curve goes in around in circles. This is your preload curve. Okay, let's see your guy. Okay, that's your pressure over volume curve. This is your mitral valve opening, mitral valve closure, aortic valve opening, aortic valve closure. Okay, so these are going to be correlated to this. What you see here, this is the mitral valve closure point, which is right here. Okay. This portion here is isovolumetric contraction phase. Okay, because we're looking at the ventricle, inside the ventricle. So we're not looking at the aortic waveform, we're looking at the intraventricular waveform, which is the ventricular waveform. Okay? That, you see it that it doesn't look isovolumetric. Why? Because it's a pressure over time curve. Versus the pressure over volume curve is linearly upwards because there's no change in volume inside the heart at that time. But that correlates to this portion. Now, why am I teaching you this, right? I mean, why does it matter? Okay, one of the things that didn't really come across when I looked at the final exam a little bit, where some people were drawing stuff, was that the aortic valve is an indicator at a point what the afterload is at. If afterload goes up, okay? Which means that you're going up this line. Let's say the afterflow goes to here, okay? That means that the pressure generated has to get up to that before the valve opens, okay? Well, it also is going to change here. The valve is going to have to go higher to generate before the valve opens, okay? That's when the valve will open here, okay? So as a consequence, what's going to happen to your diastolic pressure? Is it going to be there or is it going to be higher? It's going to be higher. So people with high blood pressure also have high diastolic pressures. Okay? So it also tells you that the afterload is going up. Okay? Now, when you have the aortic valve opening, which is here, that's this point, and this one's here, I'm sorry, and then this one's down here. Okay? Then you have the ejection phase. This phase is the ejection. And that has to do with this phase. Let me erase this because it's getting too cluttery. Okay. So this phase, which is the stroke volume phase, is correlated to that. Okay. See how the waveform looks very similar to the aortic waveform? Okay, it is. Okay, because it's generated by the ventricle in the pressure volume curve. Okay. Eventually, you get into a mitral valve closure point. Okay. That has to do with this. Okay. And what does the aortic valve closure point have to do with? It indicates to you what? It indicates to you where the contractility line comes across it. Okay, there's a contractility line that we create that goes right through the aortic valve point. So if I increase contractility, okay, what's going to happen to my curve up here? It's going to get wider. Okay, this is what I want you to start to understand. You're going to have to look at these waveforms when you get to clinical, and you have to interpret what you're looking at. If you just want to memorize that, okay, as a waveform gets bigger, my contractility is improving, that's fine. Okay. If I see my curve actually gets smaller like this, okay, it doesn't mean that the contractility is getting smaller. It could be that there's not what? There's not enough volume, okay? Because the other component that you have to look at is this velocity curve here. How fast this velocity curve is, okay? If you have increased contractility, guess what happens to this curve? It goes more vertical like this, okay? So contractility is expressed in two ways. That's why we have a very hard time figuring out exactly what contractility is just from an A line. You have to look at how fast the velocity is going up and how long it keeps going. What an important point that you really have to pick up in clinical, which will cause somebody to die if you're not paying attention, is if you see something like this happen. And this has to do with contractility. If you see the patient all of a sudden develops this, okay, that's the ventricle coming down this way. What's happening? Nope, you're actually losing contractility. The velocity of contraction is so slow that you're not ejecting anything. So this person will have hypotension, and the A-line waveform will look very slow and sloppy. Okay? You've actually seen this, you just don't realize it. If you worked in heart rooms, okay, you've seen people that all of a sudden the A-line sort of dampened out. You're going like, what happened? Okay, and the reason it's happening is the person's having ischemia, and they're not contracting well anymore, and now the A-line waveform looks like it's becoming lazy. That's a really bad sign. Okay, you don't want to see that. Okay, if you see instead that the A-line waveform looks sharp and upstroking, that still means that the heart's pumping fine, but it's lacking in volume. Okay, so those are the kind of things that you need to start trying to put together over the next few weeks as we begin to continue to talk about this. Also remember that this is related to your QRS complex. The way you find the C wave is always look at it for the QRS. It's right underneath it. Okay? So the electrical activity comes first before the actual contraction takes place. So the QRS is present right at the C wave, which is a good way of finding where your preload volume is at. Remember, your preload point in this graph is right here. That's right when the mitral valve closes. So So that's your maximum amount of volume inside the ventricle. Okay? Any questions so far? The way I still expect you to know this for exams is I expect you still to know everything about these waveforms. I expect you to know the A, C, and B waveform as part of the atrium. Okay? Also as part of the PA occlusion pressure. You also expect you to know the ventricular waveform differences between the pulmonary artery waveforms. This becomes extremely important when you get to a clinical, when you have to float a swan in somebody. You've got to be able to know what the waveforms look like. Okay? You can't be going like, well, I don't really know what I'm looking at. It's not the time to do it. Okay? You got to spend the time now, understand the waveforms, and then you'll be fine when you get to clinical. Otherwise, you're going to be lost. This is your pressure volume curve. Once again, it's not going away. At least in my mind, it's going to be part of your education while I'm here. So continue using this for now. Okay, electrical activity real quick, and then we'll go on to the next chapter or next hour. The initial electrical activity is generated by the atrial, the SA node, which is generated as a P wave. The P wave then allows electrical conduction to go through the atrium, which then causes atrial contraction. There's a PR interval, which is a time interval where the SA node sends a signal and then holds it at the AV node. So the PR interval is really a signal and hold time in the AV node. If somebody asks you, is there any electrical activity in the AV node, the answer is absolutely yes. The reason it's isoelectric is you just can't see it. Okay? But there is electrical activity in the AV node. It's just being held temporarily, and it's so deep that you can't really see it very well. Once it sends a signal through the His-Purkinje system, it generates a QRS wave, which then causes the propagation of the electrical signal to go through the myocardial cells and causes ventricular contraction. Okay? Eventually, you get what's called repolarization, which occurs in the T wave, where the potassium begins to pour back out, and the cell goes back to its resting memory potential state. Einthoven's triangle, which is a generation of the three major lines, which is line 1, 2, and 3. The way you always have to remember is where the arrows are going. Line 1 is going this way, line 2 is going this way, and line 3 is going this way. When you put it into a Cartesian plane, the line 1's in the middle, line 2 is 60 degrees to it, which is 2. Then you have another 60 degrees from there, which is 120, which is line 3. In between, which is the AVL that leads, this is AVF, okay? AVL and AVR. Okay, so each one of these lines is 30 degrees in rotation, okay? But you got to know where the arrows are pointing. The arrows are pointing to the direction of positive charge, okay? So when you look at the electrical activity, and students have this a very hard time. And you know what, I was a student just like you, so I understand the difficulty, okay? But when you're looking at an EKG, you're looking at what's called 12 leads, right? It's basically looking at the elephant in 12 different directions. Okay, it's still the elephant. Okay, well, in this case, the heart. Okay, but you're basically looking at it in different directions, and just because you think you see the nose and the other one's got the butt behind it, it's still the same heart. Okay, or the same elephant. It's just that depending on which portion of the body you want to look at, or which portion of the heart you want to look at, it depends on which portion that arrow is pointing at. The best way to look at that portion that you're looking for, you want to point the arrow towards it, okay, or going through it. Okay, if the arrow's going at 90 degrees to it, you will not be able to see it. Okay, this is the Cartesian plane. I don't expect you to memorize, how to figure out axis, but I do want you to do an easy way of doing it. This is lead 1, and the easy way to do it is by looking at lead AVF. This one's positive, and this one's positive in this direction. Okay, negative is this side here, and negative in this side here. Now, here's how I want you to think of this. Okay, when you're looking at axis, okay, the normal axis is between plus 15, okay, all the way to minus 15 to plus 110 is usually normal. Okay, so most people's axis should be over here somewhere. Okay, that's the normal axis somewhere over there. Okay, if you get a left axis deviation, which means I take this plane and put it up against my back, whichever my hand rotates towards the left, that's a left axis deviation. That could be a left bundle branch block, okay, which could be an example of a conduction defect. If it goes to the right, it could be a right bundle branch block. Okay? And knowing which one you're looking at is important clinically. So the way you figure it out really quick is look at lead 1 and look at lead ABL. Because most of you guys work on a 90-degree plane. Most of us have been taught always on a Cartesian XY plane. Okay? So the idea of having you go into different than that, I'm not going to expect that right now. Okay? So just go to lead 1 and lead ABL and then look at the EKG. If you see in lead 1 the following in the QRS, okay, and then you see in lead AVF, you're going to see the following. Okay? This is what? Everything on this portion of the EKG is what? That's positive and this is negative. So how much of this QRS is positive? It's most of it, right? Now if you wanted to be specific, you can actually measure the height counting the number of boxes. So let's say we have 5 boxes. Okay, 5 boxes in height. So then I'm going to just put 5 boxes. 1, 2, 3, 4, 5. Okay? So I'm playing battleship is what I'm doing. Okay? Then I look at AVF, sorry. Okay? And AVF looks this way. Okay? And how much is this negative? This is negative, right? How far are we going to do it? We're going to go 1, 2, 3, 4. So we're going to go 4. So it's negative, so it's on this side. 1, 2, 3, 4. Okay? Now I'm just going to drop a line across this way, 90 degrees, and drop a line across this way, and then that's my final point, and that's my axis. So this person has a what? Left axis deviation. Okay? That's how simple you can do it. This is how I want you to do it in the OR. Okay? You can do it really quick, and you can differentiate somebody that's having left versus right bundle branch block. If it's all of a sudden the QRS changes in direction, you can figure it out pretty quick. Okay? Under normal conditions, you end up seeing lead 1 and AVF should be both what? Positive. Okay? So if they're both positive, in this case, let's say let's make it normal. Let's say that's our normal one. So we're going to make it 1, 2, 3, 4. 1, 2, 3, 4. So this one's going to be across this way, and that's going to be right in the normal axis. That's how you actually figure out axes. You have to look at the individual waveforms that you're looking at and then make sure that you have it on the Cartesian plane and draw it out. I don't ask you that. I just want you to know on the test which axis it's in, if it's normal or not. Is it right or left axis deviation? Okay. So how would you get a right? You get a positive AVF and a negative lead 1. Okay? So when you see negative lead 1, you know that you should be possibly in the right bundle branch area. Okay, right axis deviation. This is to show you the normal range, minus 15. In this case, it looks like minus 20, all the way to plus 110. Every book is a little bit different. I wish they would be consistent, but everybody sort of writes it a little bit different, usually 1 or 2 degrees off. It's everything in the normal axis is normal, and outside that's left and right. You also have another way of measuring things, which is looking at the heart from a coronal plane this way, okay, which is the V leads. Okay. V leads are very useful for looking at the left ventricle. Sorry, the inferior wall can be looked at through the anterior leads, which are these. Okay, which you can look at. It's in the inferior lead, which is 2, 3, and AVF. But if you really want to look at the left ventricle, you have to look at the V leads, specifically the one arrow that's going through it. Okay, when you draw the heart, here's the heart, and here's the ventricle inside here. The arrow that's coming through the back here is going here. So what's the best lead to monitor for ischemia of the left ventricle? V5. Okay? That's why it works that way. Wherever the arrow is pointing, it matters. If you move the lead and put it here, are you really doing V5, even though the machine says V5 on it? No, you're doing V2. Okay? So you have to put the lead in the appropriate place so that the arrow is generated to it. Wherever you put that lead at, that's where the arrow is going. So if I'm putting the brown lead, if I don't put it here in the mid-axillary line at the 4th intercostal space or the 5th intercostal space, I'm not really measuring V5. If I put it up anteriorly, then I'm actually measuring V2 here. If it's on this side, it's V1. Okay? So be very careful when you do things in the OR. Now, if I asked all of you to draw how you actually put leads in your ICU, I would get 10 or 15 different responses, which is really frightening to me. I've never understood that. I've worked in many units over my career, and I still don't get it why people are not consistently placing the leads in the right place. Okay, when asked why they place it that way, and the answer, this is our protocol. Okay, right? Don't you follow the normal standardized format? And the answer is no. So we try to follow a standardized format. So from now on, if you were taught a certain way, you got to go with a standard format. Standard format is white lead, either anterior or posterior. If you want to get a better lead placement to see the ventricle, you need to put the white lead posterior. Okay? Black lead, so that's lead 1. Okay, that's your first arrow. Okay? The next one is your red. Okay, red goes from white to red. Okay? You try to put as low as you can to the hip. If not, at least put it below the V5 lead. So that gives you lead 2. That's one that is to monitor for arrhythmias because it's going to the center of the heart. So it's going to the SA node, AV node, his Purkinje system. So it's going to give you the best sign of arrhythmias. Okay? Then you put the green lead over here, okay, or down on the lower aspect. The green lead doesn't really matter too much, but the clinical portion is what happens if all of a sudden you lose all your electrical activity? You have nothing on the screen. What does that indicate to you? Green lead came off. It's the only lead that if you take off, you'll lose everything. Okay, you can take the white lead off, the black lead, everything else you can take off, and you'll lose maybe one of the waveforms if you're doing a dual waveform. But the green lead, as soon as you pull it off, it's gone. That's how you know that you've got a green lead that's misplacement. Okay, if you see one of the waveforms that's still there, then the green lead's still on. You don't have to bother checking it. Just look for the brown or the red. That's one that came off, or the one, the black or whites, depending on which lead you're looking at. Okay? Any questions? Okay, we'll take a 10-minute breather, then we'll start talking on conduction problems next.